Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to crack one more important topic under respiratory medicine, that is your pulmonary thromboembolism. Important topic, so let's crack in a nutshell and we'll make the topic simple. So in this video we are going to learn pathophysiology to practice, a visual clinical guide to etiology, diagnosis and tired management. So it's a lengthy management. You need to know everything in a bare minimum way. So first we need to know the origin, predisposing factors, how it actually causes. So we have genetic and acquired. In genetic we have protein C deficiency or S deficiency, which means protein C and S plays vital role in. Then we have factor V Leiden mutation. Then we have hyperhomocystinemia. Just remember these three, which comes under genetics. And there goes acquired. It may be due to recent trauma or surgery, prolonged immobilization. It may be malignancy, pregnancy, estrogen containing pills, varicose veins and even nephrotic syndrome. You need to remember why nephrotic syndrome is because there is a reduce in the antithrombin 3 factor. Then coming to infections, we most recently it has been famous, it's a COVID-19. Then coming to the how this pulmonary embolism is caused from DVT. Just see, there is a clot formed in a lower limb, and you need to know that we call that as deep vein thrombosis. So when this deep vein thrombosis in the venous system, it enters with IVC, then it enters superior right atrium, then from there right ventricle, and it enters the pulmonary circulation. So in this slide you learned from DVT how it enters the pulmonary circulation. No need to worry, just read well, listen to the video. You will get the PDF, download it from the description part, and just revise so that you will be thorough with the thing. Then coming to the anatomy of symptoms. So the particular symptom, why it occurs, so we have to know the cause. So to the increase within the pressure or in the vessel, which leads to rupture. If there is any rupture, what happens? It leads to bleed. So we call it as hemoptysis. Then coming to, if there is a lung ischemia, it causes cellular injury, which may lead to release of inflammatory mediators. Then what we call it as pleuritis, which leads to chest pain due to exudative pleural fluid. Then there will be reduce in oxygen transfer, which leads to hypoxemia. There is a difference between hypoxemia. Reduce in the saturation level is hypoxemia. Reduce in oxygen level is your hypoxia, right? Okay. Then coming to how pulmonary embolism is right heart failure condition. So as I said, from IVC it enters to right atrium, from there it enters to right ventricle. So there will be clot here somewhere, which leads to dilatation of your right ventricle. So clot creates obstruction, which increases right ventricle pressure and which causes right ventricular dilatation. So which leads to movement of interventricular septum to the left side. Since it is pressing, there will be less space for the blood accommodation in the left ventricle. So underfilling of left ventricle will be seen, which leads to reduce in the cardiac output and leads to the deadly manifestation, shock. And the cardiovascular collapse is why blood pressure and right ventricular function dictate the urgency of the treatment. So as these two are the deadly combination, you have to diagnose the condition very fast and have to manage the patient, otherwise you lose him on the bed. Then coming to a basic terminology, cor pulmonale. So you have to remember, when it is right ventricular dysfunction, it may be purely from cardiac and purely from respiratory. So when it is related completely to the respiratory, we call it as cor pulmonale. I guess it's simple. So let's read the definition. Right ventricular dysfunction due to primary respiratory causes, excluding disease of left heart. Okay. Then we have carpulmonale is divided into acute and one more is chronic. In acute condition, the most common will be pulmonary embolism, which is the topic of this today's video. And in chronic, we have COPD, ILD, bronchiectasis, sleep apnea, which is obstructive, obviously. So in acute condition, you will see hypoxemia. On long standing, you'll going to convert the acute condition into chronic, which leads to symptoms like pulmonary vasoconstriction persistently, which leads to pulmonary hypertension. Kindly go and watch pulmonary hypertension. Even that is important video. It has been already made available in the playlist. Then which leads to right ventricular dysfunction. The defective work well score, this is one of the 3 marker. You have to just by heart it so well. In MCQs they just give the score. Then they will ask you at what score, like what you're going to manage the condition and all, they'll be asking. So just focus on the thing. Hook or crook, you need to buy at this. It is one like in atrial fibrillation we have chart score, like that well score is also important in respiratory condition. So when there is a signs and symptoms of DVT, since we discussed our first slide related to how DVT will be converted to pulmonary embolism, right? So it is not like I included just because to say how clot came from down to up. We just added that point because you need to know that part in the well scoring properly. So if there is any signs and symptoms of DVT, you have to go for a 3 in a score. Then alternative diagnosis less likely than pulmonary embolism, we have to give that suspecting as a 3. Then heart rate more than 100, we will give 1.5. Immobilization more than 3 days or surgery within 4 days, 1.5. Prior pulmonary embolism, or like we can say history of or DVT. Not current condition. If there is a history, you have to give 1.5. If there is currently signs and symptoms of DVT, you need to give 3. No need to get confused. Then hemoptysis, we will give 1. Hemoptysis, why it has been occurred? Due to rupture of vessels. Then there will be, if there is any malignancy, we have to give 1. So after knowing that, the thing is like you need to remember whether it is red, yellow or green, under which the things will come as a content. So we have 1, 2, 3, 4, 5, 6, 7. 7 and magic score in this video is it's 4. So you have to go, since this is a serious condition, you have to spend people's money with a cautious, because the patient is in an emergency and you don't know they brought money or not. You have to be very cautious about asking what investigation you have to undergo, the patient has to undergo. So when you say something, you have to be careful in such condition. So if there is a well score, you have calculated it, and if there is a well score above 4 or below or equal to 4. So if there is below or equal to 4, it's low likely to be pulmonary embolism. So we have to go with the 500 rupees test, that is D-dimer, which is a initial. See, it has more sensitivity than specificity. Yeah, what means sensitivity? It will, like, if it comes with a positive, we can suspect. If it comes as a negative, there is nothing to worry. So D-dimer, if it is of normal, then exclude pulmonary embolism. There is some other cause, you have to check in further for other causes. Then if there is like well score is more than 4 or D-dimer is positive, you have to go for a 10,000 rupees test, that is CT pulmonary angiograph. So let's see this is a 500 and this is a 10,000, which patients burden will be varying a lot. So you have to be very careful before writing any investigation in such condition. Then coming to, let's learn it in detail, not in detail, we can call it as briefly, because it is important so that you don't forget anything in a detail. So if you give D-dimer as a screening test, what basically you are going to test is fibrin degradation product. So sensitivity but not specific, as I said. Then CT pulmonary angiograph, it's an investigation of choice in identifies defective filling defect, low dose CTPA used in pregnancy because it may cause teratogenicity. Then we have lower limb venous ultrasound supplemental to rule out DVT. Then we have VQ scan, limited use, used if contrast intolerance exists. CT pulmonary angiogram is having a contrast thing. If the person is not tolerant to that such kind of investigation, then you have to go for VQ scan. Then we have gold standard. It will be completely what you say, like gold standards are best, but we don't usually recommend regularly. That is invasive pulmonary arteriography. it is a completely invasive procedure where you will go into the pulmonary artery and you will check the thing. Rarely used in practical. Then coming to ECG and echo signs, one best sign if you want to say like if this is present in the ECG, it will almost confirm the condition, that is S1 Q3 T3 pattern. So this is important. Then coming to classical findings, right ventricular hypokinesia, we see McConnell's sign. In what this is 2D echo. This is 2D echo sign. We see McConnell sign, but in ECG we see S1 Q3 T3 sign. Then coming to classical findings of chest X-ray. Usually chest X-ray doesn't show anything. If there are some findings, then we'll see Western mark sign, Hampton's pump, and Pallas sign. So Western mark sign, Hampton's hump, Pallas sign. So Western mark sign is focal oligemia due to reduced pulmonary blood flow. So you can see there is a reduced blood flow which leads to oligemia. Then we have wedge-shaped opacity due to pulmonary infection. Obviously, when there is no blood supply, tissue is going to die. So this is what happened in all three. So, and one more is like there is no blood supply to the front side. So it will be obviously dilating at the particular site where more blood is accumulated due to clot. Then coming to, before going to the management, let's see how the case comes to the casualty. Let's take 45-year-old female with acute dyspnea, pleuritis, and chest pain with hemoptysis after a long haul flight. Her BP is 110 by 80 mmHg. So then what, after seeing such symptoms, you are suspecting pulmonary embolism. So you are going to order the investigation. As I said, D-dimer is a cheaper version. So you can just rule out, since it has higher sensitivity than a specificity. So we need to rule out whether it is yes or no. Then if it is yes, D-dimer has been increased. You done well score, it is more than less than or equal to 4. Then you order D-dimer, it has been increased. So you have to confirm the diagnosis. So there is a prominent filling defect in CTPA. It is coronary thrombopulmonary angiogram. Then we'll go to, after confirming, we'll give the diagnosis as pulmonary embolism. So we have to manage with the anticoagulant. So stratifying pulmonary embolism acuity. Here we are going to consider pulmonary embolism into massive, submassive, minimal. So in massive, it is characterized by shock and right ventricular dysfunction. So when you say it is a shock, if systolic is more than less than 90, or there will be drop in more than 40 mmHg, or need vasopressors. Right ventricular dysfunction, we say it is like dilated right ventricular on echo or CT, elevated troponin BNP. So in this condition, we say it's a right ventricular dysfunction. So what is the management? We have to give 500 ml NS with vasopressor plus anticoagulant is a must and should. Since there is a clot, you have to degrade it. So then after giving this much, the patient will be stabilized for the present time. Then you can go for a definitive treatment like thrombolysis or surgical embolectomy. Then coming to submassive pulmonary embolism, you have to see like it will be characterized by normal blood pressure. So there is no shock, but there will be right ventricular dysfunction. Normal BP, but as I said, when it is called right ventricular dysfunction, there will be dilated right ventricle on echo or CT, and there will be elevated troponin or BNP, since there is a tissue death of a myocardium. It will be released. So we have to go directly to the anticoagulants, which is must and should, and you have to monitor closely. If patient develops hemodynamic compromise, then you have to go for a definitive treatment, that is your thrombolysis. Then coming to minimal pulmonary thromboembolism, here everything is fine. The patient is having a mild symptoms, so you have to go with the anticoagulant. You can manage it with like a outpatient potential. Then coming to the specific management, massive, as I said, you have to manage with the immediate management by IV normal, saline 500 ml plus vasopressor plus anticoagulant. Thrombolysis is preferred over surgical embolectomy. We prefer non-invasive methods first, and if things are going wilder, then you have to intervene. Goal is to restore pulmonary blood flow and hemodynamic stability. And even here, start anticoagulant and closely monitor. Then here though, the one thing you need to notice is anticoagulants is must in all condition. Okay, don't forget. Then coming to the pharmacological thing, we have to discuss important part. So thrombolysis, it has high acuity. We give altiplase. The major side effect of this drug is, chief risk is it increases bleeding. Since we are reducing the thing to which is promoting what you say clotting thing, we are going to reduce it. So clot formation will be reduced, but the side effect is where there is any if any required of clot formation is there, since you have inhibited the thing actual natural barrier, it is going to cause bleed. So that is the main side effect. So patient has to be cautious when he is on the treatment. So anticoagulation strategies we give in a, let's take in a pathway 1, 2 and 3. So first we'll go heparin bridge to warfarin. Heparin will be given for first 5 days. Since warfarin takes time, we'll be giving parallelly, and on the 6th day we call it as takeover day of warfarin. Then we can stop the heparin. Heparin followed by dabigatran. It's a thrombin inhibitor. Then we give rivaroxaban or apixaban. It's a factor 10A inhibitors. So how you can remember rivaroxaban? Rivaroxaban. So in the name only we have 10A. Okay, I think that's enough for what do you say to remember better. Rivaroxaban is a factor 10A inhibitors. Then we have advanced what do you say, it's fine if you don't know this, but you can remember, like it's a interesting thing. IVC filters, an umbrella like device placed in a inferior vena cava physically to block the emboli from reaching the lungs. So the thing, DVT goes through the inferior vena cava. If you place a filter at the site of inferior vena cava, it doesn't go up. So it is indicated in recurrent pulmonary embolism despite adequate anticoagulation, active bleeding or strict contraindicated to anticoagulation therapy. Since there is any bleeding disorder or something, I think this is preferred over the what do you say your anticoagulants. So this is one page you have to remember well. So let's summarize the thing so that you people don't get confused at the end, and this is the page at the end you need to just study and go and write. So this is a pulmonary and pulmonary hypertension. These two are important topic. This is a video of pulmonary embolism and I already uploaded the pulmonary hypertension. Kindly go and watch. It is also one of the important topic in your respi topics. Okay, pulmonary embolism, most common presentation, there will be shortness of breath, chest pain, hemoptysis. Then we'll be doing CTPA. First we'll be doing D-dimer. If we are suspecting it is increased with a well score, then we have to go for a CTPA. And we'll give treatment as a anticoagulant plus or minus, with or without thrombolysis. Then coming to pulmonary hypertension, just a revision of the before video. It's a shortness of breath. There is no other two extra because there is no bleeding and all. And confirmatory test we will be doing catheterization. Then the most important treatment will be treat the underlying cause. Group 1, which has specific treatment, you have to go through the video. Don't forget to watch my pulmonary hypertension video where I gave so much of time to explain you people very detailedly how pulmonary hypertension actually causes and other thing. And I think this is all for video. Don't forget to subscribe. Yeah, you can tag me on Instagram, that's called like Brainless Medico. Don't forget to subscribe. Thank you.